to say a few words for us. Professor Tong, please.
Okay, thank you, Wei Ji, for introducing. So as the president of APOST, I'm very glad to welcome you to the second course for this year. Even with the situation of COVID, we managed to run about 5 courses this year. So this is our first year course for this year. And today we'll have a section on lectures, basics and fundamentals of endoscopic ear surgery, as well as some of the techniques in microscopic ear surgery. Then 2 weeks later, we'll have a demo. We will use temporal bone and cadaver demo, and I'm sure Wei Ji will introduce to you the different topics. I also have to sort of predict that while vaccination program is started for most target countries that APOST is training or helping to train these specialists at all levels, we'll probably restart our hands-on sections outside the usual training centers towards the 3rd or 4th quarter of this year. So and we hope that next year we'll catch up with more hands-on. Once you've participated in this basic fundamental webinar, as well as the observation of the temporal bone dissection, we might go ahead to organize some more shortened courses for those candidates who fulfill initial requirements for these basic lectures and demo. So without delay, I'm handing back over to Dr. Cheung to tell you what we're having today.
Okay, admin, can you share the screen, please? So I will start. So we are APOST. So APOST, we have a mission to promote training and education of otorhinological surgery in Hong Kong and also in Asia Pacific region. And we develop strategic action plan and training program for the professional otolaryngologists in Asia Pacific region to provide comprehensive programs. So both on practical and also emphasizing on complementary principle and techniques. So we are apart from the lecture, we have also hand-on. So also to work with any society, association, or personal for purpose of developing educational training. So we have a panelist and training board members from all over the Pan-Asia countries, and including Professor Tong. We have lectures like today. Before we have do real life lectures, hands-on and dissection demos, supervised hands-on dissections in various Asia Pacific countries. Now, in the time of COVID, we have online training, e-learning platforms, and hopefully in the future, maybe we have a video 3-dimensional hands-on, maybe, let's see. So for this APOST basic year surgical training, we aim for a very fundamental basic knowledge. We have lecture today, and we have cadaveric demonstration on the April the 10th. So the time has a little change because we have a longer time for demonstration in this time. So you please note the change of time on that cadaveric demonstration on April the 10th. So today we have very honored to have Dr. Barry Tang from Singapore, and Dr. Alexander Saxby from Australia, and Dr. Professor In-Suk Moon from South Korea to have a talk on basic otological tips and pearls and very basic otological tips. So there will be an MC questions following each lectures using a pool function. Please join us. And a Q&A section will be arranged after the last lecture. So you may leave your questions in the Q&A box here, or you can raise your hands during the Q&A sections. during April the 10th, we have cut it half and half. On the initial half, we have a basic temporal bone dissection by a microscope, and the later half we have endoscopic ear surgery basic demonstration too. So for further information, you can also go to the Facebook of the APOST and our website for the updates, or you can email our secretary for the support. So without delay, may I invite our first speaker, Dr. Barry Tang. So he will share with us the otology operation, preparation, and precautions. So this is a very basic but very important things to listen. So hi, Barry. Thank you.
Thanks, YZ. I'm going to share my screen now.
Yes, please.
Okay, just like to check that everyone can see the screen.
Yes,
yeah.
Perfect.
Okay, great. Okay, thank you, YZ, for the very lovely invitation to join you all here on a Saturday afternoon. I hope everyone is well. And best regards also to Prof. Michael Tong. It's been a long time, but I'm sure he's keeping well. Today, I've been given the pleasure to introduce you to the fundamentals of ear operations, how to get prepared, as well as how to avoid complications and maybe some typical problems that you may encounter during your ear operations. And we're going to keep it very simple. I've got plenty of photographs as well as some simple videos, and we can go through some of these very, very basic surgical preparatory steps. And then I'll be happy to answer any questions at the end of the presentation. So without further ado, let's get started. So as you know, the ear is broken up into the external ear, the middle ear, and the inner ear. And therefore, when you're talking about otology operations or neuro-otology operations, we've got to be aware of what type of operations we're going to be performing on that particular day. External ear operations run the whole gamut of anything that involves the external ear, from the auricles such as penis, pseudocysts, preauricular sinuses, microshare reconstructions, and so on, all the way into the actual bony ear canal, which may require you to remove exostosis, to widen the canal, as well as widen the external auditory meatus. Well, we've got middle ear operations, which will test different types of surgical skills. And they run from very basic tympanoplasties and myringoplasties to more advanced ossicular chain work, such as ossiculoplasties, reconstructions, stapes work, as well as nowadays with the advent of many surgical hearing implants, the insertion of many middle ear, active middle ear implants. Much of the bread and butter surgical skills that we pick up in the otology theatre is with regards to our preparations for tympanomastoidectomies. And there's a whole variety of different types of mastoidectomies. And I would highly encourage each of you to read up on the many different types of mastoidectomies which are available. And then as you go into the otology theatres, to keep your eyes peeled and to watch for the difference in the surgical techniques as you perform the different types of mastoidectomies. In terms of skull-based operations, neuro-otology operations, as well as inner ear work, I think nowadays many centers perform cochlear implants, which probably by and large will be very more straightforward inner ear operation. But you will run into larger skull-based work in terms of having to deal with the labyrinth, in terms of translabyrinthine approaches to the cerebellar-pontine angle. You've got vestibular nerve sections, as well as facial nerve decompression operations, and the bigger lateral skull-based operations, such as the infratemporal fossa approaches, as detailed by Hugo Fish. So, when we talk about the fundamentals of preparing for a ear operation, I've broken it up essentially into 5 different components. And I think it is important for us to bear in mind that each of these 5 components plays a very vital role in a successful ear operation. And so the first fundamental is that you must know your patient, that the patient is adequately prepared for surgery. Next, you must know your staff as well as the supporting attending personnel who will be assisting you for the surgery. Next, you need to know the various types of equipment and resources available to you to perform the surgery and to get them prepared for the surgery. Next, you need to know your operation itself, the ins and outs of why you're doing the operation, as well as the technical steps of the operation. And then lastly, you need to know yourself. So knowing your patient is the first prerequisite in preparing for an operation. Yeah. So before you begin and list a patient for the operation, you must be clear that the indications are met for the operation. And as part of the necessary preoperative assessments, I usually have a certain level of checklist, which I will run through my mind. And they basically will assess the hearing function of the patient in terms of audiometric evaluations, determine the extent of the disease by performing the necessary preoperative imaging investigations, assess the overall fitness for the operation by determining the comorbidities, as well as ensuring that the patient is fully aware of the outcomes, the necessary follow-up, as well as his role and her role in ensuring a good surgical outcome after the surgery. So all that counseling must be performed in the clinic consult before we reach into surgery. And finally, if we're talking about hearing restoration work, then the option of all the other hearing aids as well as hearing technologies needs to either be explained, offered, or trialed prior to listing for a surgical hearing implant surgery or hearing restoration surgery. Next, preoperative preparations are necessary to make sure that the ear is prepared in time for the surgeries. If there's any active chronic suppurative otitis media infections, these should be treated beforehand. And also any preoperative preparations and planning with co-surgeons such as your neurosurgeon colleagues needs to be finalized. Support being provided by vendors to come in to support for surgery should be organized as well. Next, you need to know your staff. And when I mean your staff, I mean all those around you who will be necessary to assist you for a successful operation. And generally, these would be surgical assistants who may be medical officers or doctors themselves who will be assisting you for the surgery. They will be your strap nurses as well as the circulating nurses who will be getting all the necessary equipment ready and to assist you in the surgery. The anesthetists, the attendants, the technicians, as well as the vendors. These are all the people who will be physically present in the operating theatre for different types of surgeries. Next, you must be aware of their relevance to the operation and where they should be sitting or standing in relation to you when you're doing the surgery. Next, you must ask the question, how can you maximize each staff that's assisting you such that your life as a primary surgeon is more comfortable, is more straightforward, and you can perform the surgery easier. You need to prep each member of your staff for what you are going to do. And oftentimes in many operating theatres, there will be a preference list detailed for each primary surgeon. And it is to your benefit to ensure that the preference list is kept updated. If you want any special surgical instruments to be ready, these should be all in your preference list so that the nurses can prepare them in advance. So I'll just briefly talk about each member of your team that will be assisting you for the surgery and how you should be thinking of their role in assisting you for surgery. I'll talk first about the surgical assistant, and this may be an assistant surgeon, someone who may be either more junior or even more senior than you. But basically, the surgical assistant usually helps to facilitate the surgical steps that you'll be performing. And the surgical assistant is usually necessary to prepare all the necessary scans, forms, check and set up all the necessary technical equipment, position the patient, give the local anesthesia, clean and drape the patient, and perform the surgical timeout. And his or her role in this intraoperative assistance will be usually to prepare the earlier operative steps or to provide traction when you need retraction, provide additional irrigation, and to prepare grafts and prostheses as you carry on with the main bulk of the surgery. As for the strap nurses and the circulating nurses, their role will be to open and to correctly stand by the necessary equipment sets, to troubleshoot for any obvious equipment failures and to help you get moving with regards to handing you the necessary equipment for your surgery. Oftentimes in many theaters nowadays, there are TV monitors, which helps everybody keep abreast of what's happening during the surgery. And this will be necessary then for you to help the nurses with these TV monitors to preempt the next steps of the surgery. The anesthetist is necessary to help facilitate a smooth surgery by ensuring that anesthesia is appropriate. If you're using facial nerve monitoring, they must avoid paralysis. And oftentimes nowadays, they use many different types of intravenous medications to help control the BP, reduce the intracranial pressure, etc. Attendants and technicians are necessary to help you with positioning of your various types of equipment and in positioning your patient. Lastly, a word about vendors. The vendors are there to support you, especially if you've got specialized equipment that you need support in, as well as if they need to provide their subspecialty services, such as if they need to perform the neuroresponse imaging and neuroresponse telemetry, if you're doing cochlear implant work, and they're there to help troubleshoot the equipment that you will be using. Next, a very important component will be to know all the surgical equipment that you need for the surgery, and they run the whole gamut. Be aware of the entire operating theatre setup. Your operating table is an important piece of equipment, and you should facilitate your knowledge of how the operating theatre rotates, turns, tilts, moves, and also the available space underneath the tabletop, which is necessary for you to place your foot control instruments. Next, you need to know your microscope or your endoscopy tower, whether you're doing EES surgery or microscopic surgery. You must prepare all your non-power instruments. These will be basically all your microsurgical instruments as well as special EES surgical instruments. You must take care to ensure that you've got all your necessary power instruments, such as your high-powered drills. You've got all the necessary electrophysiology monitoring, such as facial nerve monitors on board. Your prosthesis implants and their backups must already be present in theatre. And if you need special biological materials and resources such as gel foam, Surgicel, bone wax, poke wicks, tissue glue, etc., these should all be available as well in the theatre and ready to be opened when you need them. You should run through a pre-operative check before the patient goes under anesthesia, and then thereafter, checking the patient to ensure that you've got the correct site of the operation. And oftentimes nowadays, many theatres require you to mark on the skin of the patients before you actually wheel the patient into the operating room. You can use an otoscope to check on your last otoscopy before anesthesia to ensure that the ear is dry, and to answer any last questions from the patient to address them before he or she goes under anesthesia. Check and reference that the necessary investigations are available in the operating theatre, that the scans are there, the audiograms are there, any previous histology or microbiology results are quickly available for you to review. And check that the necessary pieces of equipment are all working before you actually clean and drape the patient. So let's go through some pictures. This is just a picture showing the CT scans of a patient that is currently about to be put under anesthesia for ear surgery. So ensure your scans are ready, available for review. You look at your operating theatre setup and ensure that your operating theatre has electrically motored operating table, which is able to control its movements, whether it can tilt, whether it can rotate side to side. And you should pay attention also, as I mentioned earlier, to the available space underneath the head of the patient, where you will usually be operating, because that's where you can be placing much of the foot control instruments, such as the powered instruments that you'll be using. This is a general setup of what most operating theatres would look like. And the components, you have the operating theatre, the anesthetic unit, you've got multiple trolleys to house instruments such as your diathermy, as well as your facial nerve monitor. You need to have free space all around the head of the patient for you to be able to position all the rest of your equipment as well as your staff that will be assisting you, and then adequate space for your nursing staff to prepare their trolleys. Different picture of what an operating theatre would look like. One key piece of equipment will obviously be your operating microscope, and you have to be familiar with your operating microscope and how it operates. Many operating microscopes nowadays are powered and motorized, and so you need to be familiar with the controls of the operating microscope, and they have recording facilities in a large number of microscopes nowadays. So first up, as part of the pre-operative check, I always check the eyepieces of the operating microscope. And here you will see two problems with this particular eyepiece and lens setup of this microscope. And I'll leave you some time to study this first, and then I'll show you what is wrong for each of the problems of this operating microscope lens. So the first problem is that the zeroing of this particular lens is not at the 0 mark. So here, in terms of the operating lens and operating microscope, you are able to correct for any of your own myopia, and you can correct it using the plus and minus function and rotating the dials. And so if you're able to zero it, and if you wish to still operate with your own spectacles, then you should ensure that the entire eyepiece is zeroed, both for the lens as well as the reference 0 mark. The second is that many of these operating lenses actually have a telescope function. And you can see that the telescope of this right-sided lens is extended outwards, is telescoped out, whereas the left is telescoped in. And you must bear in mind that both lenses should be at the same amount of telescope. So my usual preference would be to telescope this particular operating lens all the way back in, right next to the turn dial of the operating lens. Next, you need to know your interpupillary distance, and when that is comfortable binocular vision for yourself, and you should test that for yourself. Next, the positioning of the handles are important, and here you will see the position of the handles placed downwards vertically, but that's not my usual preferred position of the operating microscope. My preferred operating microscope position for the handles is to have it flung out as wings that are widely extended outwards. This is so as to avoid these vertical handles catching the shoulder of the patient as you are trying to get close to the patient. You'll find that if these handles tend to be extended vertically downwards, they tend to knock into the shoulder and restrict your versatility of movements of your operating microscope. So I tend to prefer to wing out my operating microscope handles. Next, the ideal articulation of the elbow of the microscope should be between a 45 to a 90-degree angle. It should not be extended more than 90 degrees. If it's between 90 degrees and 180 degrees, then there's less maneuverability of the operating microscope. Definitely do not operate with the microscope entirely straightened out at a 180 degree angle between the two arms, because that severely limits the rotation and the maneuverability of the operating microscope. Next, many operating microscopes has a side viewing arm, and this side viewing arm changes the weightage and the balance of the main body of the operating microscope. So it's necessary for you to have the correct weighting and balance of your operating microscope, and you should check with your technical staff how to correctly balance your microscope such that when you press the release button on the microscope should remain perfectly weighted. And the ideal movements should be that with your little movement of your forehead on your head against the lens or eyepiece, you should be able to just move the microscope lightly. And the eyepiece should not swing up and down wildly when you press the release button. for optimal balance. Again, this is an example of a side viewing arm of the operating microscope. And the controls of many of these electronically powered microscopes nowadays will have different settings. This references the focal length, the light intensity. And so in this setting, always check before you use the microscope whether it is correctly positioned for an otology case. Here, you can tell that from the focal length of 400 millimeters, this is incorrect. This is actually meant for larynx work. And so you need to reduce it down to 250 millimeters or less for otology operations. And the light intensity for otology operations, my personal preference is to increase the light to its maximum capacity. Next, you need to know the functions and the controls of the operating microscope. Nowadays, there's a zoom function which magnifies and brings you very close to the operative field, but which then makes the awareness of the surrounding structures less obvious to you. The focus needs to be correctly focused, and many operating microscopes also have a focusing beam that's incorporated into the viewing pattern. And then this is just an example of just surgical grade over the microscope. The positioning of the microscope is important relative to you as the surgeon. My personal preference is always to have the operating microscope come in directly opposite from me, and then to have, as I mentioned, the articulation angle of the elbow between the two arms of the operating microscope at between 45 to 90 degrees. Yeah. Another alternative position for your operating microscope would be to come in from the head of the patient, directly north of the patient. But that would then mean that your surgical assistants will have to stand either on your free end on your right or directly opposite you to pass instruments to you. In this position where the microscope comes in directly opposite to you, then you've got the freedom of having your surgical assistants as well as your nurses stand on either side of you as the operator. A word about the operating theatre lights. They often have similar articulating arms, and you should ensure that these articulating arms are like open elbows towards each other. So these two arms articulate quite easily during the operation. In terms of the choice of the operating chair that you'll be using, I would recommend a chair which has the ability for you to move the seat up and down, as well as to have the position of a backrest. So that would then allow you some lumbar support when you perform your otology operations. A comfortable seating position when you operate would be to have your lower back resting against the lower back support of the operating chair. You should not be sitting ramrod straight up, otherwise you fatigue. And in fact, this lower back rest is providing very essential support for a long otology operation. Next, you must make sure that all the necessary pre-operative equipment is ready before getting to the patient. And this is a pre-operative tray that prepares much of the critical components. There will be local anesthesia that's prepared, a shaver, a marking pen, a facial nerve monitor. If you need to do some markings with methylene blue, that's already provided, and you've got some pre-operative surgical marking templates if you're doing a cochlear implant surgery. Ensure that all the necessary drills are pre-selected and primed to the strut nurse so that she doesn't have to go searching for your surgical drill bits during the middle of the surgery. And you should be clear about what type of drills you want to use, the cutting drills as well as the diamond drills and the functions of the different drills. There are different handles for your power instruments, for your power drills. You've got straight handles as well as you've got angled handles. Generally speaking, the angled handles are used primarily for intracanal work, whereas straight handles are preferred if you're working back to front doing mastoidectomies, and they're not so much in your way because you've got a wide saucerized view. But if you've got a very narrow canal to have to visualize through, then a narrow shaft angled handpiece for your drill would help with your visualization. Just make sure all the necessary other pre-operative equipment is necessary and set up on your surgical trolleys that will be held primarily by the surgical nurses. And then finally, some basic steps as you head into preparing the patient. You need to position the patient, prepare the operative field by shaving, wrapping the head, giving some local anesthesia, marking the incision, setting up the facial nerve monitor. You need to clean and drape, set up the irrigation bag, and then set up the operating microscope. And then finally, you can be ready to begin your incision onto the skin. So just a few pictures to show you what a typical operating theatre setup would be like. So first up, again, the operating theatre. This particular head piece of the operating theatre should be as telescoped as far north as possible so as to give you as much space beneath the head of the operating table so that you can place all your diatomy pedals as well as your drill pedals, etc. Yeah. And then at the same time, there are the facilities for strapping the patient in, which is necessary because as you rotate the table side to side, you need the patient to be secured to the table so that he doesn't fall off. Some simple videos to go through. Here we've got just some simple videos showing preparations of shaving, and I'll skip through much of that. But basically, when you're doing post-oral incisions and work, you need to ensure that that space around at the back is adequately shaved. And I usually like to shave approximately 1 centimeter behind the temporal hairline. There are many ways of securing the hair. Hair really gets into the way. This is just one of many methods, and this was one method which I used to do. I don't necessarily do this much elastoplast onto the skin nowadays, but as you can tell, with this method, the skin as well as the hair is kept well away from the incision site and is nicely covered, nicely exposed for your incision. In giving the local anesthesia, it's just very simple. There are many different spots to give the local anesthesia. You may want to give it intracanal at the spine of Henle or circumferentially within the canal itself. You can infiltrate from behind the auricle and find your way to the posterior EAC skin and watch for the bleb even as that is injected. Mark out the entire extent of the surgery and the post-oral incision. I usually like to go into the hairline when I'm doing my modified radical mastoidectomies and hide my incision in the hairline. And then I'll give the infiltration throughout that entire incision spot. Yeah. Next, facial nerve monitoring has become essential and in fact medically, legally required in many instances nowadays. And you just need to prep the necessary areas. Yeah. So you've got EMG electrodes that will have to be inserted into the orbicularis oris, and you just need to make sure that they are adequately inserted and then positioned. So that's the active electrode that will monitor the eye, and then followed by the lips. And then you've got a ground electrode, which will be inserted into the sternal area. And after you've inserted that, you need to plug it in. So plug it into the facial nerve console with the ground electrode to the green, the stimulating electrode into the stimulator. Switch on the machine, set up your otology setup, identify the orbicularis oculi as well as oris, see and note that you get waveforms and the sound when you tap on the electrodes itself to indicate that there is movement of those muscles that will be detected by these EMG electrodes of the facial nerve monitor. And the general settings, you should set the volume at between 40 to 45 or 40 to 50 on the setting. You can set your event thresholds for them to beep at a particular voltage, and then you can set the stimulation rate on the facial nerve monitor. Cleaning and draping is very standard, and I think most of you have your own methods of cleaning and draping. But generally speaking, just make sure that the entire region all around the ear is prepared. Most times, surgical head drape is used, and you need to just wrap the head. So we'll just skip through this a bit. clip the head, dry the field, insert your irrigation fluid pouch, secure that in, and usually ways of securing would be various types of sticky tapes, which can then retract the ear and expose the mastoid area. So this is a typical preparation of a mastoidectomy. And then eventually put a anchoring towel for some weight. There's various types of irrigation bags which are used, which are also pre-prepared and which can be used in your operating theatre. I won't go through these surgical steps of harvesting the temporalis fascial graft and the inferiorly based musculoperiosteal flaps and the middle temporal artery flaps. I think we'll reserve issues like these as well as techniques like these to the dissection hall, as well as inserting all these ribs, as well as drilling. I'll leave that to the dissection hall because these are all practical steps which I'm sure Dr. Chang will demonstrate to you. I set up the TV monitor so that basically everyone can keep abreast in terms of what's happening in the operating theatre at that time. Other specialized pieces of equipment and techniques, you can collect bone dust as you drill, and there are different collectors, bone dust collectors, such as this. You can position and prep the patient in different formats for skull-based surgery. This is a typical positioning for a patient with a translap approach to the CP angle. Whereas this is a typical retro-sigmoid approach positioning. This is a typical mid-fossa approach positioning as well, with exposure and shaving done to half of the head. Next, you need to know your operation. Besides knowing your equipment, you should revise the anatomy as well as the landmarks before you go in for your surgery, especially if these are some of your first few cases. Then revising the surgical anatomy is very important. Buy and invest in good operative textbooks. Do a mental run-through before actually performing the surgery itself. I would recommend that you highly familiarize yourself with the aims of the operation, the steps of the operation, the operative principles, any special techniques which will be necessary for the surgery, how to get out of trouble, and potential complications that you can get. Now, let's talk about how to get out of trouble with some common problems that you may encounter. Firstly is to recognize that the complication has happened. And when it happens, you have to, first of all, stop and think. Don't immediately react. If you feel that the complication that has happened is beyond your means to address, then please call for help. And these are some of the potential problems that you may be encountering and some of the things that you can do. The most common problem that you encounter will be bleeding. And if you encounter bleeding from the bone, it's a variety of methods that you can use to identify, to stop that bleeding. You can use a diamond burr and burn the bone dust or burr the bone dust into the bone itself, the bone surface that's bleeding. You can use a flat tip diatomy or a bipolar diatomy also on bone to secure hemostasis. You can apply adrenaline patties as well as soaked cotton balls to do that, or you can apply bone wax onto bone to stop bone bleeds. However, if you've got soft tissue bleeding, and especially if it is arising from the sigmoid sinus, then you may need to bring on board additional pieces of biomaterials and surgical equipment such as thrombin gel foams, Surgicel, fibrin glue such as Flow Seal. You may need to harvest some muscle plugs to plug any significant tears in the sigmoid sinus. And ultimately, you may need to also be familiar with how to skeletonize the sigmoid sinus and to tie it off. Very seldom will you be encountering a bleeding from the internal carotid artery. When you do skull-based surgery, lateral skull-based surgery, you may encounter that. But for the large bulk of your basic work, you should not be encountering that because it is not in the common anatomy for basic surgical operations of the ears. If there's an injury to the cochlea or to the labyrinth, which puts sensory neural hearing loss at risk, then you need to be aware of some preemptive steps which you can use to prevent that from happening. If you're doing middle ear work and you're using a drill, You may wish to divide the incudose, the PDO joint prior to drilling around the ossicles. Be particularly careful whenever you're in the middle ear with regards to the stapes. Be aware of where the stapes is at all times, because any accidental knock to the stapes may actually accidentally mobilize or fracture off the stapes foot plate. You may get a sudden dead ear as well. Do not blue line the lateral or the posterior semicircular canal just to clarify their positioning. Be careful with cholecystoma matrix, which may be hiding fistula into the lateral semicircular canal. Leave that matrix or the granulation tissue to the last bit of your work. And then when you are able to remove that matrix, be prepared to immediately plug it with bone wax, or by putting a little bit of tissue glue over a little bit of temporalis fascia or some form of material. The CSF leak, if you do encounter CSF leak, then you may wish to do a few things. You need to stop the irrigation first and see how active that leak is and what size of a defect in the tegment is. There are several materials that you can use to correct for CSF leak, usually at the tegment. You may need to harvest a little bit of bone chips, temporalis fascia, cartilage to insert through the defect in the tegment, and then to support in a multi-layer closure, sometimes with the use of tissue glue in order to overcome some of these defects and to seal it. And of course, if the defect in the tegment is too large, you may need to convert to a mid-fossa approach to correct these large CSF leaks. Finally, a word about facial nerve injuries. Prevention is better than cure. When operating close to the facial nerve, always drill with long longitudinal drill strokes. Use the largest drill possible, and always have your facial nerve monitor at hand. You can always confirm the positioning of your suspected location of the facial nerve with a nerve stimulator. And once you have an exposed epineurium, try to leave it alone, put some adrenaline patties, let the bleeding stop first. If you have an accidental hemitransection, it may be better to convert it to a clean division rather than to have, like, for example, a drill injury where there is a lot of maceration of the facial nerve itself. And then to aim for immediate reanastomosis. Yeah? And in which case, oftentimes, you may need to call in some of your colleagues, either the reconstructive surgeons to help you with the nerve reconstruction, or if you have the skill sets, you can also do a primary reanastomosis yourself. Lastly, my last slide is probably the most important slide. I think you need to know yourself when you go in for a ear operation. In particular, you should know your own surgical limits, your own familiarity with the surgical steps. If you're not confident of performing a certain surgical maneuver, patients are not there for experimenting. The temporal lab is there for you to experiment and for you to test your own surgical skills. And I would proposition that as you enter into the operating theater more and more, you should develop that ability to know when your surgical limits are reached and then when to back off. Yeah. And with that self-awareness, I think you will be able to also improve and learn from mistakes as well as clinical experiences, surgical experiences, and to improve yourself thereafter. That's my last slide. So I thank you very much for your attention today, and I'll pass the time back to Dr. Chang.
Thank you very much, Barry. And it's a very meaningful and useful advice for all of us. So before we go to the next topic, and we will have a Q&A very last, and possibly you can save your questions. But we are going to test on you. So there will be an MCQ questions before the next start, and then we'll put on pause. So please answer the MCQ questions now. Okay, we'll give you 1 more minute to answer the questions. Okay, all these questions are prepared by Dr. Tang. So do you want to go through the, the answer with us?
I think most have gotten it correct. Yeah. So in preparing for an otology operations, important to ensure all the following, except it's not so necessary to ensure that the technical status check of the equipment is done by the technical staff. You may want to do that yourself. You definitely want to ensure that all the scans, audiometric evaluations, and all previous surgical notes should be available for you to review. In securing bone bleeding hemostasis, then the correct answer should be that Surgicel, which is oxidized regenerated cellulose, is not usually applied to the bleeding bone surfaces to secure the hemostasis. Bone wax can be used, diamond drills to burn the bone dust into the bone surface, as well as diathermy on the bone surfaces. They are all used as methods, but Surgicel usually used primarily for softer tissues. With regards to operating microscope sighting, I think everyone has already identified correctly. If you put it on the same side as a surgeon, it severely restricts the maneuverability of the operating microscope, but at the same time, it also limits the positioning of all the assistants around you. So most have gotten it correct.
That's great. Thank you, Barry. And oh, by the way, do you usually communicate with your anesthetists where they put their anesthetic machines on while you're placing a microscope?
Yes, I usually like my anesthesia unit at the foot of the bed, away from the head, because the head space is, or even the side body space, is actually prime real estate for all members of my other surgical team. So I like to have long connectors and the anesthetist far away as far as possible. But of course, they're part of the team. So long as they can hear what we're doing, it's all good.
Great. Thank you. So thank you, Barry.
Yeah, thank you, YZ.
That's good. Very good. So without delay, shall I invite Alex? Hi, Alex. Hello.
Hi.
Hi, Alex. How are you?
I am well.
Nice to see
you all.
you. Hello. So maybe okay. So Alex, Dr. Alex Hesby is from Australia, and he is going to share with us the tips and pearls for mastectomy and cholecystectomy surgery. So after we knowing all the preparation, now we go into the surgery.
Super. Okay, so I'll share my screen. Can you hear me okay?
Perfectly.
Brilliant. I don't think there's any sound, but I'll share it just in case. There we go. So,
yep.
This is working?
Yes.
Great.
Great.
Well, it's very nice to be here. It would be much nicer to be there, but hopefully in the future we can have meetings again in person. But for now, we have to make do with Zoom. So I'm coming to you this evening over here from Sydney. It's very rainy here. It's absolutely pouring. It's flooding, in fact. So it's a miserable day to be out there. But we've had our temporal bone course here in Royal Prince Alfred Hospital as well today. So we've been drilling bones all day. So I'm going to share with you anyway some thoughts on decision-making in cholesteatoma surgery, some tips and pearls, which hopefully will tie in nicely with what Barry's just displayed to you. Nothing to disclose. So I want to talk a little bit about the different approaches to cholesteatoma and how it sort of changed over time. So if we look at in the past, we know that the canal wall down mastoidectomy modified radical approach has been the workhorse of cholesteatoma surgery for decades and an extremely robust and effective way of treating cholesteatoma. And microscope has ruled the waves for 40 years or so. Sorry. Thanks, Mike. Sorry, that's the rest of our team coming in. And of course, routine second look surgery. If we move more to the present day situation, we're seeing a move towards preservation-based surgery. We've certainly had the rise of the endoscopic approach and transcanal work. And we're also looking more at radiology and how that plays a part in following up our patients, particularly non-EPI diffusion-weighted imaging. And we're also looking, particularly here in Sydney, at fusion imaging. So the way we can look at MRI fused with a CT scan and how that can improve our ability to see what's happening with our patients rather than doing a second look. So there's been some changes moving through, and the future is also bright. So there is a rise in exoscope surgery, which can have benefits certainly for our posture and for much of our ergonomics. But there's also changes happening in radiology and possibly even tip-based optical guidance systems. So a lot changing, but it's important to get a sort of overview of how the way we approach cholesteatoma has been performed in the past and also how it's going to be performed in the future. But ultimately, what we're all aiming for is these three things: a safe ear, a dry ear, and a hearing ear. And if you should always keep that at the back of your mind whenever you're planning your surgery for cholesteatoma. Now, in terms of getting a safe ear, if all you care about is recurrence, and unfortunately, that's what a lot of people, all they ever think about is how can I make a zero recurrence operation? Well, the simple thing to do would be to chop the ear off. If you completely destroy the ear, you're not going to get any recurrence. But of course, what we're really aiming for is a functional ear, an ear that can hear, an ear that's dry, an ear that can perform for the patient. So there has to be this balance between totally aggressive and destructive surgery and at the same time preservative and functioning surgery. So at the moment, we have three very well-established ways of taking out cholesteatoma. We can perform canal wall up mastoidectomy, we can perform canal wall down modified radical mastoidectomy, and now we have the ability to perform endoscopic transcanal surgery. And they all have a role. It is not, in my opinion anyway, it is not that one is better than the other. They all have a role in different situations. And so what's critical is assessing your patient and determining what is best for them. And so how do we make that decision? How do we decide when we see the patient whether we're going to do a canal wall up or we're going to attempt an endoscopic approach, or whether they need a canal wall down? And the reality is there are multiple factors that come into play whenever you're thinking about this. And you need to consider all of these things when you're looking at your patient and deciding what's best for them. So the key take-home message I'd like you to consider is that one size does not fit all. You should be tailoring your surgery to your patient's needs, to your patient's disease, and to get the maximum outcomes for them. So I'm going to look at basically two things today. I'm going to look at, first of all, incisions and try and give you some tips and pearls about how to make your first cut. And then also how to make a plan, how to actually sort of plan your surgery in an effective way. So let's talk about incisions first of all. So there are three basic approaches to getting to the cholesteatoma. You can go transcanal, and that can be with a microscope or an endoscope. You can go oral, where we make another incision in the canal in order to open it up more widely. And we can go behind the ear or post-auricularly. So let's think about those in turn. If we look at the endoscopic approach, and all of these videos are available on YouTube if you want to study them later. But when we're making an endoscopic incision or any transcanal incision, it's really important to think about where you want to make your tympanomeatal flap. And my biggest advice would be, when you're making your superior incision, try and make it anterior to the lateral process of the malleus. What that achieves, 6 o'clock inferiorly is pretty reasonable, whatever the surgery, but superiorly, try and come anterior to the lateral process, because what that achieves is a flap that when you bring it down will give you access to the attic. If you come too far posterior, what will happen is this part will tear when you're trying to make when you're trying to take your surgery into the attic, which you commonly need to do for a cholesteatoma surgery. So try and make a well-sized tympanomeatal flap that will come down at the end of your operation and provide you with a good coverage of whatever repair and reconstruction you've had to perform. In terms of actually making a tympanomeatal flap, here we're using suction, actually maybe not, oh yes, this is a suction round knife, which is a lovely instrument, but this can be done just as effectively with a microscope. You don't have to do the endoscopic approach. The one advantage of the endoscope is you do get to see more clearly where you're making this front cut. So I really want you to consider tailoring your incision. This was a lovely article from quite a few years ago now by Stephen Ayachi, who talks about the idea of just tailoring that incision. You don't need to just go the standard 12/6. You can make your incision wherever it needs to be in order to effectively achieve your goals. This is an example of a patient who had a cyst in the very sort of anterosuperior aspect of their epitympanum, which you can see there on the scan. And so if you've got a pathology that's anterior and superior, then it doesn't make much sense making a very posterior tympanomeatal flap. So making a flap here, hopefully my cursor is coming up, makes little sense. So in this case, I came really far anterior, maybe 2 o'clock. And what that enables you to do, if I move things along a little quicker, is to bring that flap down over the pathology. So we're bringing the tympanomeatal flap down and carefully withdrawing the tympanic membrane over the cyst. You can see the lateral process of the malleus here. Because the pathology we were aiming for is here. Now, this isn't cholesteatoma, but I'm just trying to get principles here. So if the pathology is here, it makes no sense to come in down here. Equally, this would be particularly difficult to get through a mastoid approach. So in this case, the endoscopic approach was very, very appropriate. And then we can see entering the cyst there and the sort of mucoid discharge that was found within. In this other case, we've got a more classic cholesteatoma, and we've got an attic retraction pocket here. It's an absolute mess this here. You can see the tympanic membrane was grossly covering all of the middle ear structures. And so when you're going to make an incision here, you want to come right up and around, because when you come to repair the lesion, and what I've used here is cartilage, and if I run to the end, when we pop the cartilage in at the end, and in this case I'm using a composite tragal graft, you pop the perichondrium down onto bare bone And then the final step is this large tympanomeatal flap, which will then sit on top of your repair in a very neat fashion. Again, if you'd made your cut too, you're going to have nothing to cover that graft. But by coming anterior to the lateral process, you can then lay it on top. Okay, so moving on to the endoral incision. And these are beautiful images by Robert Jackler. That's where we basically bring the incision out along the edge between the two layers of cartilage, the tragus cartilage and the helix, which enables you then to there we go, to pop a retractor in. And with that sort of incision, you can even perform a mastoidectomy, although most people would go post-auricularly, but it gives you very wide access. So the most, I tend not to use this incision anymore because of the endoscopic approach. It's made this somewhat redundant in my practice, but a lot of people use this. If they're going to use a microscope for transcanal work, then the endoral incision can get you out of trouble if you need to get a wider view, because you can get these endoral retractors in place. So if we want to talk about post-auricular incisions, then I've tried to make these somewhat schematic drawings here, but the important thing to remember is where the ear canal lies. Okay, so when we do a classic post-auricular incision, it's something like this. And the reason we have to go all the way to here and all the way to here is that you need to imagine an imaginary line of reflection where the flap is going to come forward, giving you access to the canal and, of course, the mastoid. If you only make your cut to here, you're not going to be able to retract all of that soft tissue forward enough in order to get access. So you need to think about that line of reflection in order to make your cut adequate. But of course, what it means is you've then got quite a lot of soft tissue to retract forward before you get to the canal. So that's fine if you need to do a mastoidectomy, but not so great if you want to just do canal work. And of course, we need to shave the hair in order to get that access. So what about if you're doing a cochlear implant? Now that's a different situation, okay, because this time we're just doing a mastoidectomy. We don't want to go into the canal at all. Like, the idea is to keep the operation as sterile as possible. We don't want to go in the dirty canal. We want to just do a mastoidectomy. So in Sydney, we tend to do a fairly straight incision, not the big curving incision, because this time we want, when we retract open the skin, which is shown very schematically there, we are able to get access to do a mastoidectomy, but we don't need to get to the canal, okay? But by doing a straight incision, it also enables us to work backwards where we want to stick the implant. So we've again tailored our incision to our needs. We don't need to go all the way around to the front and all the way to the bottom here, because then we'd struggle to get the actual implant in. So we tend to do a more straight incision. If we move to exostectomy, that's the complete opposite situation where we only want to be in the canal and we don't want to do a mastoidectomy. So for these patients, I do a sulcal incision very close to the ear canal, not the big incision around the back here, so that you're not having to do all that soft tissue work. You can see where we go in just here. So that enables us to retract the soft tissue enough to get into the canal, but it wouldn't be enough to do a mastoidectomy. So again, we've tailored our incision for the operation. When you're doing a translab or skull-based procedures, you want to think about the anatomy. And so if we put the traditional mastoidectomy incision on, it's not going to be quite big enough for what we want to do. So we take it back further. So translab incisions tend to be a little bit wider than the traditional mastoid. Again, tailoring it to our needs. If we're doing a retrosig operation, again, we're going to come this time behind the sigmoid. So we want to make a little craniotomy here. So it's more appropriate to do an S-shaped incision further back. So again, what I'm trying to get across to you is that one size does not fit all. There is not one post-auricular incision. There are multiple ones. Okay, so I'm going to move on to the second part of the talk. I really want to look at the idea of getting a plan together. So when you're dealing with a cholesteatoma, there's a lot of things to consider. Okay. And in any surgery, you really should think about doing the operation at least 3 times. So first of all, you want to do the operation in your head when you meet the patient, when you see their scans, when you look at the disease with the microscope in your rooms. The second time you're going to do the operation is the real thing, okay, the actual operation. And the third time is when you're driving home that night and thinking, you know what, I wish I'd done that. And next time I do the operation, I'm going to do that because that wasn't very effective the way I did. And so it basically, you're self-appraising yourself, okay? You're looking at how you could do the surgery better the next time. And really, that's the way you're going to improve. But having a good preoperative plan is half the battle. Okay, if you know roughly what you're going to do when you get into the surgical room, you're going to have a much better time when you are in the surgical room. So the preoperative plan needs to consider all of those factors you saw before. We need to think about the patient. How old are they? What are their comorbidities? How reliable are they? How likely is it I'm ever going to see them again? If it's not very likely, then you want to do a very definitive operation. You want to err more towards the modified radical than the preserving surgery of endoscopic approach, because those surgeries have a higher recurrence rate. And so if you don't think you're ever going to see the patient again, you have to factor that into your decision making. You also need to think about the disease. If it's a small attic retraction pocket, then do you really need to do a huge mastoidectomy? If the lateral semicircular canal is compromised, should you really be doing an endoscopic approach? Or should you be doing a mastoid where you can control it more safely? So these are all the considerations you need to take into in order to decide where that ball's going to land on that game. Then there's hearing considerations. And very importantly, what is the status of the other ear? If they've got a dead ear on the other side, and this is their only hearing ear, then you need to be very careful about what decisions you make for this ear. If it's a cholesteatoma, then you think, but whatever you do has to make sure that you preserve their hearing. And then there's surgical considerations. So what's your training? What's your experience? What's the equipment available in your hospital? These are crucial factors. So when we look at a CT scan preoperatively, the problem is that cholesteatoma and sequestered fluid look exactly the same. So in this case of cholesteatoma, we don't know whether the cholesteatoma ends here, whether it ends here, or whether it fills the entire mastoid. One way you can get around that is the fusion scanning I was talking about. And DWI can illustrate here, this is the same patient, that in fact, the cholesteatoma appears to only be in the middle ear, not extending into the mastoid. And there's another example here. So there are some clues you can get from using clever technology. And the situation we don't want to be in is one where there's small attic disease. There's the entire cholesteatoma pocket. But to get there, an unnecessary huge mastoidectomy is being performed. So that's why making a preoperative plan is so important. Equally, if we take the opposite situation where you've got a highly sclerotic mastoid, this mastoid here, this is an axial temporal bone scan. You can see on the left-hand side, he's got quite a pneumatized mastoid. Whereas on the right-hand side, it's highly sclerotic. It's mainly bone, okay? And so in this situation, when you've got an attic disease, it's not going to be that appropriate to do a canal wall up mastoidectomy. You're going to be drilling through solid bone. So in this situation, you're either going to want to do an endoscopic approach or a canal wall down approach, but probably from an inside out direction. So again, there's no right or wrong answer, but you need to appraise all of those different factors in order to make sure you're doing the best by your patient. So I want to go through with you then an intraoperative plan. So when you've actually started the operation, how do you make sure you're going about it in the right way? And this is just one way of doing it. So I always start in the canal. I think getting that tympanomeatal flap correct is really crucial for the last part of the constructing. So if you get the tympanomeatal flap exactly where you want it, in my hands with an endoscope, then even if I then go on to do mastoid work, at the end of the operation, when I'm bringing that tympanomeatal flap back, which is the fundamental aspect of getting a good tympanic membrane reconstruction, then I find I get a better job. You can just go from behind and transect the canal, but you're unlikely to get those cuts exactly where you want them. And I find that starting in the canal achieves that for me. Once you're inside the middle ear, you want to assess what's going on. You want to make sure, is this cholesteatoma, or is it in fact cholesterol granuloma or granulation tissue or something else, or tympanosclerosis, like true tympanosclerosis? What's actually going on, and what's the extent of the disease? You want to define the status of the ossicular chain. So by that, I mean, you want to know pretty much the main thing you want to know is what's happening with the incudostapedial joint. If that's eroded, if you know you're going to have to do an OCR, then get the incus out, get the head of the malleus out, because it's going to make your life so much easier and quicker. If, however, the ossicular chain's intact and you think you're going to try and preserve it, then you know you're in for a long and difficult dissection of trying to pull the disease off the ossicles. But if that decision has been made for you, if the IS joint is already eroded, then you can speed things up by just taking the incus out, taking the malleus head out, and then proceeding to the mastoid or doing what you need to do. But get an early appreciation of what's happening with the ossicular chain. In my hands, I then remove the disease from the middle ear, okay? One of the advantages of doing that is once the disease is out, then the bleeding and the potential complications of having inflammatory tissue there settle down. So if you can get the disease out safely, again, in my hands with an endoscope, I will do all of that work first before I move to the mastoid. So when you're working in the middle ear, you want to be methodical. You want to find your landmarks. And I've got a little, and you want to work methodically. You want to clear area by area. And if you see a little collection of squame, try and get it out there and then. Don't think, oh, I'll get that later, because inevitably you forget it or you leave it, and that's going to be the area that recurs. So if you see cholesteatoma, try and get it out there and then. So step 5 for me is determining if the mastoid is required. So if you're chasing a cholesteatoma back and back and back, you have to come to the point at which you say, I'm not going to get this out transcanal, I need to turn to a mastoid. Or if your preoperative scan showed you that it's really extensive and you know you need to go to a mastoid, then make that decision early so that you're not taking too long, because if you know you're going to need to do the mastoid, then get on and do it at that point. In all cases, you want to leave the most complex parts of the dissection to the last. So if there's a tegment dehiscence, if there's a lateral semicircular canal dehiscence, if you have disease caked on the stapes, try and clear everything else out first, and then work on those difficult areas right at the end. And then finally, we need to think about reconstructing the hearing. Are you going to do a primary OCR? Are you going to stage it? In my hands, if it's not too inflamed and there's a stapes superstructure, I'll always do a primary OCR. If, however, the superstructure is gone, even if there's a mobile foot plate, I'll always stage a TORP. I think when you've got to reconstruct the attic, you've got to reconstruct the tympanum, you've got too many other factors going on. In my hands, you're better off repairing all that, staging it, and then coming back and putting the TORP in later. So I'll only do a primary PORP, not a primary TORP. And finally, you've got the anatomical reconstruction itself. So you've got to reconstruct the tympanic membrane, you've got to reconstruct the attic, and of course, you've got to think about the mastoid cavity and how you're going to close that. So I'm going to go through each of those points now in a little bit more detail. When we started in the canal, we've talked about making that decent tympanomeatal flap. And I'm going to show you this little video, which was just from a case last week. Yeah, I think it is playing. So here we've got a young boy who's got a large perforation in the posterior aspect, but he's got skin extending up into the retrotympanic area. So you make your tympanomeatal flap, and I aim to enter the middle ear fairly low so that you avoid the chorda tympani. So come in low and then work the drum out of its sulcus to about 6 o'clock. And then you want to divert your attention over to the chorda tympani and also the superior aspect, the pars flaccida. And when you're working in that area, you basically want to find your chorda. Chorda is your landmark. And then we tend to use a cup forceps in order to bring that soft tissue out attic region, from Prostac space. So by gently pulling with the cup forceps, which is more an endoscopic technique, I'll admit, than a microscopic one, but it gives us this beautiful view, and you can see the lateral process of the malleus coming into view. And with a bit of suction there, you can see the neck of the malleus and the lateral process. So what we've done there is take the chorda, which we can trace up to the neck of the malleus. We found the lateral process of the malleus, and then we can start to dissect along the course of the chorda, because we know that's going to be a plane of dissection. And we're using longitudinal dissection, much like Barry was mentioning before. If you go in a longitudinal plane, you know you're not going to disrupt that structure. And then another safe plane to work in is that plane between the malleus and the long process of the incus. So as long as you're dissecting in this plane here, which we're doing with a small joint knife, taking the drum off the incudostapedial joint, that's a fairly safe space too. So it's a case of finding the anatomical landmarks. Get into the middle ear, see the round window, get your bearings, find the chorda tympani, follow the chorda tympani to the neck of the malleus, find the neck of the malleus, find the lateral process. Parallel to it, you're going to see the long process of the incus. Follow the long process of the incus, you're going to find the stapes. So using those landmarks is critical, because in some situations, it's all granulation, it's all cholesteatoma, and it can be a nightmare. So use your landmarks step by step, methodically. In terms of deciding when you're going to make that mastoidectomy, sometimes the disease makes the decision for you. The cholesteatoma's eroded so much of the attic that the decision is made. You have to decide if you're preserving the acicular chain. We've talked about that before. There may be other factors like a fistula, which are going to make you more likely to want to do a mastoidectomy. And there can be predictive information from your preoperative imaging. But the long and short of it is you can make a small adicotomy and do a mastoidectomy. The good thing about that is it's easier to reconstruct. You've got a small adicotomy that you can fit a piece of cartilage to. And it gives you the opportunity of preserving the acicular chain. The bad side of it is you've had to perform a mastoidectomy, which takes more time, is more invasive for the patient, has some of the negative factors that mastoidectomy can have. The alternative is you make a larger adicotomy, which means that you may be able to complete your surgery endoscopically or transcanal. Well, that's good because it's minimally invasive and it can be quicker because you're not having to do all the mastoidectomy work. But has the downside of being a more difficult reconstruction. You've now got a larger defect, which you've got to reconstruct with cartilage, and that may lead to a more likely attic collapse. And acicular chain is most likely going to need to be reconstructed. So there's pros and cons of both. In terms of leaving the most difficult dissections until last, I want to show you a couple of things. This is a video showing a case where there was a perforation, but it was the cholesteatoma was lying all over the stapes. So this is one of those, you can see this, the squamous disease encasing the stapes. So this is one of those cases where you want to do everything else first and gradually get the disease out before you start tackling the risk case. We gently pulled the squamous disease away from the stapes using a number of different techniques, but slowly, carefully, and methodically. And eventually in this patient, we ended up finding disease lying between the crura, a particularly difficult case. So you can see us using a KTP laser there to gently take the disease out from between the legs. So in this case, we were able to preserve the acicular chain. I think she's about 6 years now post surgery and still has no sign of recurrence, which is fortunate. But in this case, we've got good hearing result because we kept her acicular chain intact. It's not always possible, but it was nice in this case. But the take-home message is you leave the difficult bits till last. If you've got a lateral canal fistula, you can do an interesting thing, which is the underwater technique, which is kind of cool because it's a combination of the mastoid approach, but then using an endoscope underwater. So I'll just show you a little video of that. So here we've performed a mastoidectomy with a microscope. We've left this till last. We've done everything else, but now the last bit of the cholesteatoma is stuck on our fistula, which we knew from our pre-op imaging. And there we gently peel off that disease underwater. The benefit being there's the dehiscence, benefit being you've got that liquid boundary. So it's hopefully less likely to cause a sensory neural loss, which we were able to achieve in this case. So hearing reconstruction is a fascinating talk. It's a talk all by itself, but basically you've got two options. You can reconstruct the ossicular chain or you can preserve the ossicular chain. If you're reconstructing, you may have to do that because the disease itself has completely eroded the bones of the ossicles. Or it may be that the bones are fixed. So from inflammatory disease, they're fixed. So in that case, you've got to reconstruct. With ossicular chain preservation, you can perform it, pull disease away from the ossicles, like we were showing in that other case and this one here. Or you can do a combined approach where you're still coming in from behind, but you're using the endoscope or other means to gently pull the disease away from an intact ossicular chain. So there's some basic ways of keeping the hearing where you want it. I think that's pretty much all I want to say, actually. So I might end there and take any questions. Hopefully that's given you some. Do I have to stop share or I'm not sure what I have to do?
Thank you. That was very exciting. And I like the underwater skills.
Yeah.
That's a perfect use of endoscope. So then you can use two hands. And what's the water do you use? Saline or? Yeah,
we just use saline. So we haven't done many. I mean, we've probably done about 10, 15, something like that. Thankfully, we don't see that much erosion of the lateral semicircular canal. Yeah. But some pro tips would be, I find it best if you put the water or the saline into the canal. So you have that running into the canal, which then keeps the stream coming over and out of the mastoid and then over and out into the bag, right? If you have the stream going in the mastoid, it tends to push your squamous disease deeper into the middle ear. So I like having the stream coming from the canal and then pushing things out and away, from where you don't want them. So that's one tip. The other thing is definitely having an assistant to do the irrigation is a must, because they can then adjust it. And you don't want to just fill the mastoid and then put your scope in. You want to have it constantly moving, because otherwise you get little sort of bits of blood coming up. And you can't see anything. You need it sort of always moving, and getting the right pace of that fluid is the key thing.
Right. Then you have a really
yeah, that's it. Yeah.
Right. So Alex, are you be able to stay until the very end Q&A?
Yeah, absolutely.
That would be great. Then meanwhile, I want to go for the MC quiz, because before the INSOX talk, we have your MCQ. Let's get started.
Sounds good. I'm very impressed with the number of participants, 255. That's incredible.
Yes, and we have a lot of trainees from different countries, and yes, they are very active. And thanks for the webinars and the COVID, we have these kind of normal webinars teachings, and most of them can join in and free of charge. And we can have more participants. Of course, we want you to be in Hong Kong.
Yeah, next time.
Definitely. Hopefully the vaccine works.
Yes, I've had mine. Very lucky. Yeah. Yes. How in Hong Kong, what's the proportion of people vaccinated now?
It just started by this month, so it's
okay,
not yet. Yeah, it's gradually improving numbers.
Yeah, fantastic. Yeah, I think we only have a couple of 100,000. We're not very many, but we don't have any cases, so we're very lucky.
Indeed.
Yeah.
paradise in
Yeah.
the world.
Super lucky. And do you know how many countries are online at the moment?
Okay, how many countries? Okay, Bonnie will answer you this question. She's doing all the countings now.
I think we have around 20 countries.
Oh, that's
Wow.
amazing. That's amazing.
Wow.
That's the power of Zoom.
Indeed.
Yeah.
And I think this will be one of the normal situation in the future. Even if we can meet face and face, we can do it hybrid.
Yes.
We can do it
Yes.
in a webinar and some in
Yes.
real life. If you don't want to do a dissection, still you need a real life.
Yes, exactly.
Hands-on. And it's always good to meet you in person.
Yes, exactly. Yes, we're right in the middle of our course. So it's Saturday evening here. So we're running our 2-day temporal bone course here today.
In the middle, so you would do the evening drilling too?
Nah, they've just finished. You heard them coming in the middle of my talk. But they've all gone to dinner now. So
Oh, thank you so much, Alex. It must be really tired and for a whole day.
No, it's all good. It's exciting.
Okay, so wait, the post end and
Okay.
Alex. Okay, can you please go through your questions quickly?
Yeah.
With us?
So I think, look, 92% are aware that they're all very important factors there in terms of how you approach your cholesteatoma, the disease, the condition of the other area is crucial, and the integrity of critical structures. So I think that's fairly clear. So regarding tympanomeatal flap and which one is true? Good. So everyone got my banging on about that more times, that we should tailor it. That's excellent. So I'm glad that message got across. And regarding cholesteatoma surgery, a sensible middle of the day. Yeah. So that's right. So basically, let's look at the other answers. Cholesteatoma can always be excised through an endoscopic route. Now, we're all big fans of the endoscope, but that's not true. Like, you sometimes have to do an open approach. There's no doubt about it. And anyone who says otherwise is crazy, because we very much have to have all those microscopic skills. Second point, cholesteatoma should always be removed by mastectomy. Well, there are certainly surgeons in Sydney that would still say that. But in my view, tailoring your approach appropriately is much more appropriate. And equally with revision surgery, there's no reason why you can't revise with an endoscope. You don't have to do a mastoid. You just have to approach every case and look at all those factors, and then you're going to do the best by your patient.
Perfect. That's a very so. Without delay, shall I invite Professor In-Suk Moon for today's last talk? He will be talking on the basic procedure of myringoplasty and ossiculoplasty. I think this is a very essential and crucial procedures for the starters and the basic trainees and high trainees. So, Professor Moon.
Yeah, hello.
Thank you.
I prepared the pre-recorded video because sometimes the network is not so good, and I want to some fluent progress. So can you share my pre-recorded video?
No problem, Bonnie.
Yeah.
Thank you.
Good afternoon. I'm In Sung Moon from Yonsei University, Seoul, Korea. Thank you for inviting me this wonderful surgical skill training workshop. And congratulations to Michael, YZ, and APOST team. Today's my talk is basic procedures of myringoplasty and ossiculoplasty. The tympanoplasty was defined as a procedure to eradicate disease in the middle ear and to reconstruct the hearing mechanism with or without tympanic membrane grafting. This includes canaloplasty, myringoplasty, and ossiculoplasty. And this term was introduced by Dr. Bluestein in 1953. And Dr. Bluestein also classified tympanoplasty as 5 categories. Everyone knows about these categories, but this category was introduced in the time without any artificial processes for the middle ear reconstruction. So we don't need to seek this classification anymore. In the 1968, the Seoul in Korea was like the left side picture, and now it's like the right side picture. So I think we need alternatives. Update. I prefer this updated classification. Dr. Merchant from Harvard University categorized tympano. First subtype is meringoplasty, and next three subtypes were ossiculoplasty in closed cavity, and last two were stabenomeningoplexy in open cavity. Today, I'll focus on first four subtypes. First, meringoplasty, and next three were ossiculoplasty in the closed cavity. This is today's content. Meringoplasty, ossiculoplasty, and stapedotomy was maybe introduced very briefly in the last part. Meringoplasty. It is population repair in the intact ossicular chain. We need to consider anesthesia, incision, graft material, and techniques. But I want to focus on my ordinary techniques. I used transcanal underlay or inlay graft with temporalis muscle fascia or cartilage under the local anesthesia. Different from retroauricular incision case, we only need to block the ear canal. For block the auricular temporal lobe, we need to inject tympanosphincter line and tympanomesosuture line. It corresponds to the 2 o'clock point and the 7 or 8 o'clock point in the ear canal. Underlay technique. This drawing is a schematic expression for this concept. As you know, tympanic membrane is composed of 3 layers. Outer side is skin, medial side is mucosa, and between the two layers is connective tissue. So we need to insert graft material under the tympanic membrane, because if we put the graft onto the skin, it will be detached very soon. Under the mucosa, it can be firmly attached, and the tympanic membrane will grow onto this graft bridge. And this is a two basic concept. Underlay graft, usually we approach it from the posterior to the anterior side, and so in the posterior part of the canal, we need to put the graft onto the bony ridge in the posterior side. So this is not standard for the underlay or overlay. We call the overlay or underlay with this anterior part. If the anterior part is inserted under the annulus, we call it the underlay. If we insert graft onto the bony annulus of anterior side, we call it overlay. Now I show the underlay technique. The first we need to trimming the population margin to make it a powerful regeneration. Second, skin incision from 12 to 6 or 1 to 5 o'clock. Then elevate the TM flap. Elevate the TM flap very enoughly, and we need to preserve coda tympanine nerve. And then harvest the graft material. We can use the temporalis muscle fascia or tragal cartilage perichondrium. And then insert graft material underlay. Underlay is, as I said, so under the fibrous annulus in the anterior side, but over the bony annulus in the posterior side. And then we need to pack the gel foam under the graft material and over the graft material. Very important thing is graft material must be not sunken down to the anterior side. So we need to pack the gel foam enoughly and tightly and properly. Let me show surgical video of underlay meringoplasty. I prepared endoscopic meringoplasty case. It's a little bit different from microscopic. Yeah, first one is trimming of tympanic perforation membrane, and then scraping the inner side, because as I said, mucosa part is the most powerful part of the regeneration, and we need to attach the graft material to the inside. So after the trimming, after the scraping, we can do the incision and TM flap elevation. Canal incision and TM flap elevation, we can see the inside of the middle ear. Check the middle ear status, check the ossicle status. Yeah, this is a cochlear, round window, malleus, and the incus and stapes. Then insert graft material. Then put the gel foam to support the graft material. If the support of gel foam is not enough, the graft is detached from the tympanomeatal flap, and then reperforation can be made. After that, taking the gel foam outside of the membrane, then we can finish. Next technique I want to introduce is inlay technique. In the very large population or near total population, we need to use the overlay technique. The overlay technique, we elevate whole the skin and then put the graft, including the anterior bony sulcus, then reposition the flap to secure closure. But even in small population, the population is far anterior, we need to overlay technique. But as you know, overlay technique is very difficult in the transcanal approach. So already showed the overlay technique in the previous lecture. This inlay technique is very useful for the anterior small population, and also now we extend this indication for the medium-sized population. This is a very simple technique. We harvest tragal cartilage and make a furrow in the lateral side and put this tragal cartilage material graft into the refreshing population margin, like the ventilation tube or button. So sometimes we can call it a button graft. In 1998, eBay first described this technique, and it's a very good advantages. We don't need to elevate the skin tympanic membrane, so we don't need to gel foam packing. The patient discomfort is quite reduced, and operation time is very shortened. This is a post-operative picture. The graft material is too thick, so sometimes the doctors worried about the sound transmission is interfered. But in many studies, 0.5 millimeter is quite enough for the sound transmission, and some report describe that the mass effect is better for the sound transmission. This is surgical video for inlay cartilage butterfly technique. In left side, I recorded this procedure using the microscope, and right side, I recorded this procedure using the endoscope. Very small population in the anterior side, so we can trim the anterior side population, then harvest tragal cartilage and perichondrium. Measuring the size of population, then harvest the tragal cartilage like this small button type, and then make a furrow. In this procedure, attaching the perichondrium is very important. Without the perichondrium, cartilage is very easy broken. And then insert the material onto the tympanic membrane, and using the pick, we can insert this using the rotation method like the ventilation tube insertion. After that, just gluing is enough, not gel foam packing inside and outside. So patient is very comfort after this procedure, and the operation time is very short. Sorry for delays. There are some technical problem in making the video. Anyway, it's the same. So I want to show the difference of the same operation, endoscopic and microscopic. The very simple method. Next topic is ossiculoplasty. Ossiculoplasty is restoring the hearing system between the tympanic membrane and oval window. We also consider anesthesia, incision, the materials, and the method. And previously, autologous materials, especially incus interposition, is widely used. And 2 or 3 decades ago, synthetic material like polycell or hydroxyapatite was most popular. But nowadays, metal, especially titanium, is widely used. So today, I also focus on the transcanal total processes osteoplasty using under the local anesthesia. The etiology of conductive hearing loss is very diverse. If we can find tympanic membrane perforation or some granulation in the CT scan, it's easy to find the etiology. But tympanic membrane is very intact and no infection or granulation in the CT scan. We just estimate or just we can only assume the etiology. If the airborne gap is big, we can imagine it's from the ossicular chain problem, and it's bigger. We just assume that it's otosclerosis. Ossicular chain problem, we can do the ossiculoplasty, but in the otosclerosis patient, we need to do the stapedotomy. This classification of ossicular chain defect is made by Ugo Peace in 2008. Very diverse, class 1 to 3. Now, today only we can focus on the class 3 in the closed cavity because it's a very basic. If we can master of this technique, we can adapt and utilize this technique to other patients. So, first one is a PORP, partial ossicular replacement processes insertion between stapes head and the tympanic membrane. Second one is a TORP, total ossicular replacement processes insertion between foot plate and the tympanic membrane. In the early days, we used autologous material like the ossicle, incus, and cartilage block. The ideal characters of the material for the ossiculoplasty is biocompatible, easy to handle, good to sound transmission, and so on. These autologous materials are very biocompatible, but not so effective, difficult to handle, time consuming to make it. So now we shift from the autologous material to the artificial materials. Second generation was synthetic materials, synthetic polymer, hydroxyapatite, polycells. Those materials were structurally stable and fair biointegration. But still, it's very slippery, so still hard to handle and easy broken. And also, extrusion rate is much higher than autologous graft. We can use the cartilage cap and reduce the extrusion rate, but still higher. So nowadays, most widely used material is metal, titanium. This titanium processes was used since mid-90s and widespread in last decade. It's very strong. So we can make the weight, so using this open type head, and it's a very strong, so not easy to broken. It makes it handle easier. And higher biocompatibility than synthetic material. So extrusion rate is lower than synthetic material. Steel is also extruded, but less than synthetic material. Disadvantage is a lack of biointegration, but in my opinion, sometimes this disadvantage can be an advantage. In the revision surgery, incus, cartilage, and synthetic material were very hard to remove. Removing that previous inserted material, sometimes we damage to the staples, but titanium is very easily to remove. So in revision surgery, this lack of biointegration is a high advantage. And we can make head and body very diverse shape. So this clipping and sometimes PORP, this shape can very fit staples foot plate. And both side clipping is also possible. I'd like to show PORP, titanium processes insertion. This video is also made using the endoscope for better surgical view, but concept and procedure is the same as a microscopic view. After incision of skin, then TM prep elevation, and then coda tympani nerve preservation, scutum removal a little bit, then checking the status of the ossicle. Touching the ossicle, then I feel the staples is movable, but malleus and incus were fixed together and they didn't move. So I decided to separate the ice joint and then remove the incus and measure the height of from the staples head to the canal and then insert PORP. You can see this shape is very fit to the staples head and then cartilage capping, pericondylium insertion, flap reposition. We can measure the height of processes, length of processes using the grid or the dummy. But if we don't have dummy or grid, we can use the landmark of the posterior EH canal height. Because from the staples head to the posterior canal is the distance of the staples head to the tympanic membrane, the same. So we can use the height of the posterior canal as a landmark. Next one is a TORP, titanium process insertion. You can see this is a staples footplate. In case of staples superstructure's absence, we can do the TORP process, feel the mobility of footplate. In this case, footplate is mobile, so I put the TORP. You can see the shape of the body and it's very fit to the staples footplate. Then capping using the tragal cartilage and then reposition of the flap. Several times checking for the proper insertion of the processes. Then we can reposition and finish. For higher success rate of ossiculoplasty, you need to support processes. Gel foam insertion around the processes is essential, and to prevent extrusion, cartilage capping is essential. And the PORP is much more stable than the TORP. So please utilize remnant suprastructure as much as possible. Last topic is stapedotomy, but the stapedotomy is not main topic in today. So I just briefly introduce the concept and surgical video. Stapedotomy is indicated in the situation of Stapes foot plate is not movable. This can be happen in many various diseases, but most frequent disease is autosclerosis. Autosclerosis is a autospongiosis around the otic capsule. So if you see this spongiosis around the otic capsule in the CT scan and a very big airborne gap, you just imagine I need to do the stapedotomy. This is a stapedotomy procedure. First step is skin incision and elevation. Take a maximum care, please, not to tearing the flesh. So it's difficult to not tearing. Then remove the scutum because we need to see the fully see the staples and incus and get the surgical space. This step is very essential. Using the curette, skitter drill, and very thin scissor and mallet is helpful. During this procedure, coda tympani is very fragile and reluctant, so not to damage it is very important. Then we can measure the distance from foot plate to the long process of incus. Average distance is around 5 millimeter, and we can choose 0.5 millimeter longer than the measured distance. This is a piston wire. Piston wire is inserted into the foot plate hole, and then this is hooking to the incus. After measuring, cut the tendon, stapedial tendon, and cut the posterior crura. We can use a crurectomy scissor, skitter drill, anything. Then drill the hole, make a hole using the razor, skitter drill, and some kind of perforator, but maximal effort not to damage it to the sacule. Sacule is a little bit not invade, is overlapped the step foot plate. So if we made a hole in the anterior side, we can damage the sacule. But middle, or a little bit posteriorly is safer. If we use the skitter drill, drilling, and then with the drilling, we can put off the drill. It's a safer. Perforator later, and then just remove this articulation of incudostapedial joint and cut the anterior crus. Put the processes and hook the processes and looping tightening with a crimper. But it's very, very, very risky and difficult. In my opinion, stapedotomy is most risky and most difficult procedure in middle ear surgery. Skull base surgery is a little bit more difficult, but in the middle ear surgery, stapedotomy is top. Yeah, this is my surgical video of the stapedotomy. Skin flap incision, then skin flap elevation. We can take the incus and stapes. Using curette, scutum removal was done first. Then displacement of chorda tympani. We can see the inside, incus and stapes. This handling of chorda tympani can damage it, but Without this displacement, we cannot see inside. After displacement of Kodak tympani, I can touch foot plate, suprastructure, and incus. So I can feel the mobility. In this patient, foot plate is very firmly fixed and not movable. But incus and malleus and the other structure was mobile. So in this case, I decided to do the stapedotomy. Yeah. Tendon and cut the posterior corona, then fractured. And then this is a posterior foot plate of staples, incus. Using the razor, I made a hole. I tried to do make this hole the posteriorly, but it's a little bit difficult to perforate in the posteriorly. So the perforation hole is made in the middle or a little bit slightly anteriorly, but I checked the status of secure. So after that, in this hole, insert the processes. Laser stapedotomy, then making it a little bit wider. This is a piston wire. Insert piston wire into the hole and hooking incus, then grabbing tightly using the crimper. This is the most risky and very fragile steps. If you do it too gentle, it's not firmly tightening, and if you do this too strongly, it make incus blocking and incus break, and sometimes piston wire is inserted too deeply. So with patience, gently, slowly, and firmly do this step. Okay, this is the end of my talk. Thank you for your attention, and congratulations again this wonderful surgical skill webinar. Thank you.
Thank you, Professor Moon. That
Thank
was a
you.
great talk and covering all the. There are a few questions, but before going to the questions, maybe we do the test for this lecture first. So 2 minutes to 3 minutes time.
Okay. How about Hong Kong nowadays?
Wow. And we just got the vaccination, so it's a hit
Okay.
topic right here. And I know you're super busy today. You have 3 talks, and we're just one of them. You're very popular.
Thank you very much. On Monday, I will be vaccinated, so I'm afraid of some symptoms. Many of my colleagues already got the vaccination, and they have some very severe symptoms. So.
Oh. We got some incidents, and we are not sure if it's related to the vaccination too. So after the vaccination, some cardiovascular event, and they were doing investigations. So, but so far okay for my colleagues, and Michael got the injection too, the vaccinated.
Okay. Some old one don't have very severe symptoms because immune system is not so strong as a young people. So maybe Michael.
I don't comment. He is old though. Okay. We have 1 more minute. So have you finished all your talks today?
Yeah, it's our last talk. So from now on, I'm free.
That's great. And
Yeah, thank you.
congratulations on your symposium too. That was really amazing.
Yes, thank you. Thank you for your great contribution. Because of your help, it was finished successfully. Yeah.
Thanks. Maybe in Japan? Do you think so?
Yeah, sure. Definitely.
In Yamakata.
Yeah, in next year. So
Yeah,
maybe in
Tokyo.
next year, April, we can gather together.
Yeah, we miss you guys. Okay.
Okay.
We wait for a little bit for the answer. Probably after 100. Yes, they're still answering. We can see the attendees are answering right now. Okay. Okay, 3 minutes. Okay, that's 3 minutes up. So we will see the polling.
Okay. Yeah, it's so the correct rate is not so high. Anyway, so the first question is very simple. The underlay and overlay, the pros and cons. In the underlay, so in the overlays, lateralization and something is most big problem in underlay. So the flap is sunken down and the depopulation is a big problem. So I want to ask this basic question. And second one, yeah, it's sometimes it's malleus, sometimes it's in closed cavity we can measure it using the malleus, and in open cavity we measure it using the facial ridge. But in my opinion, posterior bony annulus is better than the malleus. Sometimes malleus is not so confident because interposition is a best method, but interposition using the processes is the angle. Angle is too angled. So hearing result is not so good. In processes from the stapes to the eardrum. So I make my standard landmark as posterior canal or bony annulus. The last question is I sent CT scan and hearing pure tone audiogram. So without that, it's difficult to answer. So it was a stapedotomy. I sent otosclerosis CT scan and big bone gap pure tone audiogram. Yeah, that's it. That's my top question, but it's not so good for the audience. Yeah.
No, but they learned from you and they got the answers, and hopefully they learned from. This is why we make the course. We have to learn from the course, right? So there's quite a number of Q's and A's in the question pool. May I also invite Alex to join us? And
Hi, Alex.
Hi, Ansiok.
Hi, Alex. Long time no see.
Yes. Where did last year go? It disappeared.
Yeah.
Exactly. And you know what? Today is a very busy day, so all of us has more than one conference to attend. Right. Okay. So let's go to questions, and I think one question is very very interesting and meaningful, and I want to ask both of you: do you usually do a ear surgery without CT scan? I think ear surgery doesn't mean the middle ear. Maybe tympanoplasty, you may not need a CT scan, but mainly about cholecystoma, they will ask. Do you usually, for cholecystoma cases, do CT scan?
For me, cholesteatoma would be 100%. If I didn't have a CT scan, I would postpone the patient. So 100%. For me, the only time I would not do a CT would be exostoses surgery for surfers in Sydney. or with no other obvious complication. But otherwise, every cholesteatoma, every 100% get a CT.
Insok, do you
Yes,
do the same?
same as Alex. I took the CT scan 100% because sometimes cholesteatoma embed in a ear, so without CT scan, it's very dangerous.
Yeah, I agree. But I understand because our participants are coming from different countries, and in their countries, CT scan might not be that easily available. So theoretically, we must have a CT scan usually in congenital cholesteatoma, in revision surgery, and if complications arise, then you must have a CT scan. For those, if you are doing like a canal wall down, you trace the cholesteatoma set all the way, and you're not going to plan it endoscopic or microscopic, probably if you don't really have that resources, you might be able to do that, but it's not as good. So always with a CT scan, you will be able to know the anatomy, know whether there's a dehiscence, you know your risk, and then you can also plan your operation, like as Alex say, sometimes endoscopic, sometimes microscopic, and sometimes you have a combined approach. So it will be better if you have a CT. But when you have no resources, then this would be the answer. Do you have any supplement? Okay, so Alex, that's a question for you. What's the real boundary of ATIC?
Of the attic?
Yeah.
Well, the attic is really the epitympanum is what I'm talking about. There's the prosac space, which is only a small area more lateral to the true attic. And prosac spaces, the boundaries are well defined. They're the pars flaccida laterally, and then the incudomalleal ligament medially or superiorly, with the neck of the malleus and the pouches of von Trolsch inferiorly. But then the attic, anteriorly, the skull base, the middle fossa, angles towards the eustachian tube, so it comes in and narrows, and posteriorly it opens up into the additus and then antrum. So that whole area is, in my view, is the attic. Yeah, I don't know if it's actually a sort of colloquialism, because the attic for us is the top of the house in the roof. Yeah,
exactly.
It's like the roof of the ear. I don't know if it's actually a
and when you before you
term.
that's the Latin. That's the Latin of
Atticus.
the true
I guess
meaning.
so. Yeah.
Yes. So do you obliterate the mastoid cavity? They asked the best. One of the candidates asked the best option of mastoid cavity obliterations.
So for me, if it requires obliteration, it's usually a well pneumatized mastoid, and those patients would, in my hands, be either an endoscopic case or a canal wall up. So then I wouldn't need to obliterate. So it's very rare for me to obliterate, unless it's a revision case, and in those situations, I would either bring in vascularized tissue, either from above, so temporalis muscle, or from behind with an inferiorly based muscle flap, like Fish describes. So I tend to use those very rarely because I try and avoid it, rather than bone dust or other artificial synthetic material.
Yes, and Insok, do you do obliteration of mastoid usually?
Sorry, I cannot hear because the network is now not so good. Yeah.
Oh, the candidate asked that the mastoid, they try to obliterate, so fill the mastoid with something that to cover the mastoid, make it no longer a cavity. Do you do that?
With fat, tutoplast, and something, but many things. But it has its own problem because without the mastoid cavity, the original function is destroyed. So it's a problem. And also, even obliterated mastoid cavity, retraction can occur in some time. So now I don't use mastoid obliteration, but instead of that, big cartilage reinforcement is now my method, but it's also still ongoing. We will see.
Yeah, I think I agree with Alex. I try to preserve the mastoid cavity as much as possible, unless you have to. And we have a flap called Hong Kong flap that that we obliterated with a vascularized temporalis with a big.
It's a great flap.
Yeah.
Yeah.
So that's a very abundant. You can use anytime, but try to avoid. Yes. So how big is bigger if you take exactly the same size of tragal cartilage? Do you take just the cartilage or together with perichondrium? So this is your question, Insuk.
Sure.
Yeah. So maybe it's a question for the butterfly cartilage inlay graft. I prefer the cartilage harvest with both side perichondrium, because without the perichondrium, the cartilage is easily broken. And with the perichondrium, if I cut the middle, the perichondrium pull the cartilage in both sides. So cartilage is spontaneously open like some shell. So we can put the beside in the to the tympanic membrane. And also one more question is how measure the precise size. Every time it's a exact quarter size, half size, and sometimes more than half size is one of the options. Quarter size is 3 millimeter, half size is 5 millimeter, more than half is 6 or 7 millimeter. It's very easy to measure. And I can harvest tragal cartilage up to 1.3 or 1.4 centimeter. But after that, rebanking to not interrupt the shape. So yeah, that's my questions. And that's my answers.
But you don't actually need that big size cartilage, I think, for the butterfly tympanoplasty. You just need a small.
Yeah, not for the butterfly, but sometimes, as I said, attic reconstruction or attic reinforcement. Sometimes it's a bigger cartilage is better. So in that case, I harvest totally and banking apart.
Oh, that's different. So I sometimes even take down to the EAC cartilage. Yeah, you can do that. And so for stapedotomy, you cut the anterior crust. How do you break the posterior crust? All right. So do you use laser or the crimper? What method do you prefer, Insuk?
So posterior corectomy using the laser is safer, but angle and the space is too small. So inserting the laser device is very difficult. So I use a corectomy seizure. So sometimes, you can see very quite angled seizure and cut the posterior crura and the pectoral in the anterior side using the pick or some device. So that's a usual method maybe.
Alex?
I use a laser. We have a true blue laser, which is really nice if you ever get the chance. I think I saw it first at your temporal bone.
Oh, really?
And then we bought it. Yeah, I really, for the posterior cross. The anterior one is so small. I find it always breaks very easily with a right angle hook. Yeah, so I rarely laser the front, and it's difficult to get to the anterior cross.
Yeah. So you usually down fracture it.
Yes.
Yeah. Okay. So Professor Insuk, for endoscopic laryngoplasty, what are the methods of increasing canal width, like Tarabiji stitches? Okay. So do you when you do endoscopic laryngoplasty, so do you do anything to increase the canal size?
Canal size. In the endoscopic, just I have no method. How about you? Just shaving the hair and pushing the ear canal using the nasal spectrum is my own method. It's without that. How about you? You have some experience.
We use so we stopped using the Tarabichi stitch.
Yeah, me too.
Okay.
We use the Lone Stars. So we're really big fans of those. So they're a bungee cord with a hook.
Oh.
And you just hook them on and then clamp them to the patient. But the benefit is you can reapply them as you go. So when you want to take your tragal graft, you can take them off, take your graft, put them back on. I find them very helpful rather than the stitch, which requires you to cut it and then put another stitch in, and it just takes too long. And also the stitch cheese wires cuts through the skin when you don't want it to, whereas the bungee cords are nice and soft. In terms of maybe the questioner was wondering about canalplasty. So usually the benefit of the endoscope is you don't need to do a canalplasty, even if there's an anterior overhang. You can still get a good view, and certainly with the cartilage button graft, you can usually get it in. But in the situations where we do need to take the canal down, a lot of the time I'll still do it endoscopic and either use a drill, in which case it's tricky with the endoscope. You have to be careful not to drill your scope. Or if you have access to a piezo surgery, that's a very nice device for completing that part of the procedure, which vibrates the bone away rather than rotatory drilling. Do you have any advice when drilling with the endoscope? Like, do you use a diamond drill or do you prefer a cutter? Do you use irrigation or do you do it dry?
I use the very sharp shielded micro drill because sometimes there is sharp damage to the endoscope, and ordinary that ball is too thick as they fighting each other. So mainly I use very sharp micro drills.
Yeah, protected tip.
I give up the Terabichi stitches, I think, for many years. And I think the most barrier is not about the triggers. Most of them, the triggers is not obstructing our way. You can easily, by tilting your endoscope, you can get rid of it. I even don't use a Lone Star, but I think I will, for those with really long hairs of the ears, I will definitely cut it. And I agree with you, Alex, that most of the time it's the canal wall, it's the bony part that obstructing us rather than the triggers. So for me, if I really need to drill the canal, I take the exoscope. So
okay.
Yeah, it's very fast, and so nice. You prepare the exoscope, and then it's very fast. And then, I have two hands and suctions. That's nice. Easier for me. So there's a question especially for you. I have some question for you. The first question is about the inlay butterfly cartilage technique. How can we measure the size of TM? I think you have answered the answer. You estimated by. No.
It's a very nice way of getting a totally round piece of cartilage.
But you have to make sure the same size, the size is right.
Yeah,
so
like 2, 3, or 4 millimeters. They come in all different sizes, so you can choose, and then it's a perfectly round, perfect hole. Yeah, it's nice.
But do you choose the size? That I know the skin.
Yeah, I use a round knife to determine the size, measure it, and then
you open
choose my skin biopsy punch. Yeah.
Oh, okay. That's a really fast and easy way.
Yeah, and it's completely circular.
Okay. But my opinion, we need to harvest a little bit bigger than the population, so because we can make it smaller, but we cannot make it bigger. So I think so maybe not precisely 1.5 size is ideal. So it's my opinion.
Yes.
Yes, definitely.
Yeah.
And the outcome of this technique in patient hearing compared with the normal temporary less fascia graft?
Yeah, same as temporalis muscle fascia graft. I published 2 times, 2014 and 2021. So the hearing result was same. In someone told that the graft thickness is too thick, but 0.5 millimeter or up to 1 millimeter is okay. In some studies, it's no problem. Also, small mass effect can sometimes enhance sound transmission.
Yes, I think you
So-
have mentioned this in your lecture too.
Yeah.
So pay attention next time. So, and the outcome of this technique in patient, and the last question is the risk of cartilage necrosis and the cholesteatoma formation. I think if you include the perichondrium, the risk of cartilage necrosis is very small. And cholesteatoma formation, do you have any idea? That makes sense because they may have a ingrowing between the layers, and there's a possibility of going inside the middle ear rather than
problem. But if the graft is firmly and very tightly fixed, the cholesteatoma formation is not happen. But sometimes there are big gap or something is naturally slippery into the middle ear. In that case, some problems happen. But maybe less than 1 or 2%.
Yeah, I think the benefit of the cartilage is it's so strong that your recurrence, as long as you've placed it correctly and used a pericondyal broader size to hold it on the bone, it's unlikely to retract. So you're less likely to get recurrence from collapse. Whereas if you just used temporalis, it will likely retract and give you a recurrent cholesteatoma. But the downside is residual cholesteatoma. Because it's so thick, you can't see through it. So in order to assess for residual disease, you either have to do a second look or use some form of imaging, because you can't see through the cartilage. So like all things, there's pros and cons, but I really like the way it repairs the attic. I think it's an excellent material for that. But particularly if you keep the perichondrial layer attached and have the perichondrial layer larger than the cartilage, so that the cartilage locks in, but the perichondrium tapes it basically to the bone of the attic.
Okay, I think our time is almost, but there are quite a number of questions. So I'm sure the candidates won't mind if we take longer, but quick fire. Okay. So if you don't mind, we just spend a little bit overrun a little bit time. So in order to answer most of the questions. So they have a very long question is, do you pack after butterfly graft?
The gel foam packing means
any pack. No, I don't pack it. I don't pack it. So when will you do the hearing evaluation after the surgery?
So for me, 8 to 10 weeks. I can't see a point of doing it earlier. You want everything to completely settle. Anything, if it's not completely settled and tightened, then you're always going to be thinking, well, maybe it'll improve. So it's not going to change what you do. You may as well wait. So I leave it at least 2 months.
Yeah, I do it 3 months.
There you go.
Yeah, same.
Even better.
Same me. Between 2 to 3 months.
Okay, so how big is the triangle? How big is the triangle for cortical mastectomy will you perform in the area? What is the safest? Well, I think
depends on their landmarks.
Yes. So I think I will talk about this in the dissection. So make sure you attend the 10th of April, the real life dissection, and we'll talk about this and demonstrate it. Where is the local infiltration to reduce the pain in stapedectomy? Okay. So do you usually do it local insult? I saw you do it local.
Not special. Same as the tympanosquamous line and tympanomesosuture line. So maybe in the EAC, 2 o'clock and 7 o'clock, not special other side. Just waiting a little bit more is better, but no other side.
But how do you anesthetize the middle ear? Do you have any special technique?
For me, it's auriculotemporal branch block is enough for the patient, reducing the pain. Yeah.
Even the middle ear. Do you experience vertigo after anesthetizing the patient?
Sometimes the hypotympanic area is not so well anesthetized. Some irrigation and some drop can make dizziness, but we need to maximal carefully. For me, no specific site. Yeah. How about Alex? Do you have any special site for injection?
I tend to do my stapes under general anesthetic, so I rarely perform local anesthetic. Yeah.
Yes, me too. I prefer general anesthesia because of some of them, even with the local anesthesia, they experience quite some pain in the middle ear, and I think the blood pressure is better controlled under general anesthesia. So okay, the question on Alex, how do you make sure that your cholesteatoma is fully removed out of the ossicular chains?
It's a good question. Well, if you're concerned, if there's any concern that it isn't fully removed, then the ossicles have to come out. So unless you're very confident, and so it depends on the cholesteatoma. Some of them have a nice capsule that you can gently peel off in one, and you can be very confident that it's off the ossicles. And with the endoscope, you get a very zoomed in view of the bone, and you can see the dissection plane very clearly. In other cholesteatomas, if it's all fallen apart and it's in pieces and you're coming out piecemeal and you can see potential for cholesteatoma to be medial to the ossicles, then that's a very dangerous situation to leave that. So if there's any doubt, then you're better off doing an ossicular chain reconstruction, I think. The couple of cases where I've pushed the boundaries have come back to bite me and recurred. So I'm now more especially since the ossicular chain reconstructions, you can generally get very nice hearing. I really like the clip-on porps, the ones that actually sort of clip to the stapes and stay there. I get pretty good results with those now, so I'm more inclined. It's a problem.
Do you use the
I don't always get it right.
Interposition usually?
Never with cholesteatoma, but we were discussing this in our temporal bone today. So we will commonly use incus when it's a fixation or a non-cholesteatoma erosion or problem. Then we'll always use the incus and refashion it and place it either into position or similar to a porp on top of the stapes. But for me, never with cholesteatoma. It's too high risk.
Right. And question asking how common is congenital cholesteatoma in Australia? And is there any difference?
Yeah, we see. I think it's the same as everywhere else. It's common, and we see it, and it's more aggressive, and has a higher recurrence rate. Unfortunately, it's a very difficult disease. We are just writing up our series on that in terms of our endoscopic approach, but the rates of recurrence and residual are similar to microscopic work. It's but worse than our acquired cholesteatoma. It's definitely a more aggressive variety, but yeah, it's just as common here as everywhere else.
So what if it's not? If cholesteatoma is not, so you never use as cholesteatoma. If that is a granulation tissues, do you use incus interposition?
Yeah, look, if anything other than cholesteatoma, I think it's fine. Yeah.
And then you remove everything.
It's a good resource. It doesn't extrude. It's the body's natural tissue. You don't need cartilage. yeah, if you've got an intact drum, yeah, it's a great option, the Incus. And we were discussing today that it's a dying art, how to refashion it, because everyone jumps to these fancy titanium prostheses. But we need to remember the art of refashioning an Incus, because it's fun and it's beautiful and it actually works really well. What do you think?
In the maybe 10 years ago, and I tried to make I tried to use the Incus, but for me it's very difficult to drill, making shape and time consuming, and sometimes yeah. So now I fully changed to the titanium processes. Yeah.
See, it's a dying art.
Yeah. So a few questions for Insuk. And do you use Skeeter for stapedotomy? What's the bird size do you use?
Now I don't use a Skeeter drill anymore. In the first time, 1 millimeter ball, maybe 1,000 RPM or the 800 RPM was my method. But now I use a razor. So maybe a small one, 1 millimeter diameter ball using the less than 1,000 RPM is safer. Yeah.
Do you use Skeeter?
I use Skeeter. I use a Skeeter drill on a 0.6 millimeter with a 0.5 millimeter piston.
Mm-hmm.
Oh, okay.
Oh, yeah.
Okay. So I use 0.6 millimeter Skeeter. So
yeah.
So I still use 0.6 millimeters. Then you need to drill a little, shake a little bit before, or you can use a larger one, 0.8, still be okay. So which is better to do ossiculoplasty using microscope or endoscope, or stapes surgery via posterior tympanotomy or via transcanal? Stapes usually transcanal. So, but for stapes surgery and ossiculoplasty, which one do you prefer?
Good question. Well, I guess I'm somewhat biased, but I would use the endoscope for most, because I find the view is just so superior. You're just in the action. You can see exactly what using one hand anyway. So I don't think it's particularly disadvantageous to have just one hand. You have to have patience whatever you use. And I think that's the key. Like, it doesn't really matter. And sometimes if I'm struggling and I think I need two hands, bring in the microscope. Doesn't matter, whatever's best for your patient. But I generally can use the endoscope for both stapes and for ossiculoplasty.
Insuk?
Yeah, now I'm trying to do the ossiculoplasty and the tympanomeningoplasty using the endoscope totally, but still the stapes surgery, stapedotomy, so both up and up. Looking the inside is better in the endoscope, but last step is very difficult to the one hand. So it's the skill as a learning curve is important. Now from the microscope to the endoscope is my changing. So it's up to the surgeon. As Alex said, we don't feel the shame about changing the endoscope to microscope. Anytime we can use both.
Yeah,
yes,
definitely.
agree. Yeah, and ossiculoplasty, I have no problem using one hand, but when doing a stapedotomy, I think I change my prosthesis if I use endoscope. So I use a prosthesis that can be used only one hand, like the clip-on. So you don't have to climp, you don't have to like using two hands, and those clip-on is quite useful. And you change your prosthesis options, then you can tailor-made for yourself and for your patients. So last bit, I go a little bit into the skull base, and so about the facial nerve. So number one is the facial nerve when you cut it, and so what if it accidentally cut it, and you have not yet finished your surgery? So do you do you wait until the last bit and or you stop your surgery and repair the facial nerve? And in what situation?
So I've never cut it. So, that's my biggest advice. Try not to cut it. If I'm unfortunate enough to do that in the future, I think there's a lot of sense in calling a friend. You know, at that point, you're going to be so devastated with what you've just done that your skills and your mental state are going to be affected. So calling a friend, pausing, stopping, taking a break is a very sensible option. And having a fresh pair of hands to help you with the nerve reconstruction is sensible. And like In-Seok said, there are reconstructive surgeons that do this all the time with free flaps and so on. They're good friends to have on your mobile phone. So that's probably what I would do. But thankfully, it's never happened.
What a great advice.
Yeah.
That's a nightmare.
Don't be don't be shy to call. Like
Sure.
it's that everyone's here to help each other. So
Yeah. I 100% agree. So first one is doing nothing. Call your senior is or call your friends is the option, like the 911. Call your friend or the senior. Yeah, so mental status is a very, very important. So you cannot do any more in that situation. Yeah.
Okay, that's biggest advice. Call your friends. Don't do anything. Calm yourself down.
Yeah.
And I think before you have to know yourself and know your ability. Don't be too aggressive and know your facial nerve. That's why you have to attend the course.
Yeah.
Okay, we'll show you the facial nerve wherever you are on the April 10th. Okay, make sure you think you can always email us or send emails to our secretary, so they can forward the question to us and we can hopefully answer your questions. And you can always revisit, when you registered, you can revisit our lectures anytime. So I think we have overrun a little bit and I have to call it a day. And I thank you both very much for joining us and
thank you.
Very good advice.
Yeah.
Thanks so much. It was an absolute pleasure to be involved. Thank you.
Thank you.
Yeah,
Hope
thank
to
you
see
so
you soon.
much.
You too.
Yeah, see you soon.
Have some rest.
In person.
Bye for now.
Thank you, Alex.
Yeah, bye.
Bye-bye.
Bye-bye.